Hello, this is Dr. Melanson, and it's a pleasure to be with you again this week for Kidney Talks. And we have a very special talk this afternoon. Once again, we're here with Dr. Callender and myself, but we're welcoming Dr. James Griffith, who is a psychiatrist. And as you guys out there know, we've talked about this before, that there's a lot of psychiatric illness and discomfort, mental discomfort in the community. And we thought it appropriate to have an expert to talk about these supratentorial problems. Dr. Griffith is a specialist, so we're looking forward to his talk. He's going to center on depression, but he will open it up for questions thereafter, and I hope to have a healthy discussion. Dr. Griffith, welcome to Kidney Talks.
Thank you. No, thank you for the invitation. I've been at George Washington a long time, 1994. And they recruited me because they needed a psychiatrist not to see the psychiatric patients in the hospital, but the medically ill. And I'm a consultation liaison psychiatrist, meaning that I actually don't have anybody with schizophrenia in my practice. Everyone has a medical illness. And I think maybe where I would just introduce myself, and I'll talk about what I think are some important points. And then we can have questions and discussion, because there will be much more that can be discussed and we're going to have time for. Maybe a place to start, a number of years ago, the National Kidney Foundation were having their national meeting in Washington. As a psychiatrist who sees medically ill, I've seen, a lot of dialysis patients. They asked me if I would give a talk about why patients with end-stage renal disease often don't adhere to their water restrictions, their phosphate buffers, their diets. And I knew I'd seen a lot of people in the hospital, but I knew that was not representative of most people on dialysis. So, some of you probably know Dr. Lou, one of our longstanding nephrologists, also been at GW about as long as I have. I discussed this with her, and she said, well, go down to N Street to the neighborhood dialysis center, ask the nurses to pick out their best patients and some of the most difficult. So I did that, and for weeks I would interview patients and met people who would say, I leave my L Street office, I come down to the dialysis center, I read the newspaper. When I walk back out the door, I'm not a dialysis patient. I'm a journalist or businessman or whatever. And I also met patients who said, this is torment. Every time I hear somebody go to the water fountain, I feel like I'm being punished. I can't even go to McDonald's. And from this, I got the sense that if you have end-stage renal disease, it's not a given when you get up in the morning that life feels like it's worth living. It really takes some working at it. And I was meeting people that were inspiring for how effectively they can live alongside a chronic disease without it defining who they are. And on the other hand, others that really struggle with what is not depression as a mental illness, it's demoralization. So one place I'd want to start making that distinction, that if you study, and much of this, what I'm talking about right here is actually out of Sloan Kettering with severely ill cancer patients. If you study folks that have a chronic disease, and it could be kidney disease, you tend to get three groups that struggle with low mood. One of these, and this is like depression as a mental illness, feel dead inside, can't enjoy anything. And these are individuals that often do need to be treated like depression is a primary illness. Well, there's a second group where the main feature is just sadness. And these are folks that really have had many losses in their lives having to do with the illness, and there's just a lot of grief. But the biggest group is one where folks feel helpless, hopeless, isolated, desperate. And this is the group which I would say is demoralization. And I'm separating out these three groups because they have to be addressed in very different ways. The one I'm going to say less about is the first one I mentioned, the person who kind of feels empty, dead inside. You know, these are individuals that actually need expert psychiatric care and like may need to be on antidepressants. They may need to have some specific psychotherapists that we have that are targeted for depression. You know, the middle group, which are folks that are grieving a lot of losses. You know, sometimes I just say the words, I'd say 4 H's: hush, help, hang out. They need the real comforting presence of another person, which can be a mental health professional, but often this is where it's very fruitful to work with families as a whole. But the demoralized group, you know, this is the group that I have spent so much of my career. You know, patients that they feel worn down, worn out, feel trapped, helpless, hopeless. And here, the main focus of the work I've done are the ways that you can help somebody sustain the experience of hope, even if there's no good betting odds that the problems are all going to go away. And this takes conversations where, you know, if I were meeting with you, I would ask, how bad is this for you? I would listen empathically, but at a certain point, I would turn, what keeps you from giving up? When you've been through the hardest times in the past, what carried you through? And we would then bring that to your present life situation and say, from what you've learned about dealing with adversity in the past, how can we bring it here? And this is where nothing can take away many of life's adversities, but there are ways to prevail against it without it becoming your life. So let me maybe just kind of pause and summarize. And I guess if there's anything that comes quickly to people's minds when they're talking about being chronically ill, it is the low mood. It is what in the vernacular is just called depression. Only a subset of those folks actually have a psychiatric illness, depression, and need that treat. Another really needs the comforting presence, care, concern. And the group with demoralization, this is where I spend the time not so much trying to diagnose depression, but getting clear about this person's strengths, capabilities, bringing them forward to deal with this illness. Now, having said that, let me jump to what's often the big concern. If we get consulted, I'll get a consult in the hospital, maybe from one of Dr. Melikon's Baptist patients, and said, please treat my patient's depression. And I'm going through this, dividing out into groups in my head, but there's one overriding concern, which is, could this person be suicidal? And sometimes we see patients who have made an effort to end their lives. So let me talk a bit about that, because I'm going to guess that where some of the questions would be, it would be around detecting suicide risk and how do you respond to somebody who has active thoughts of doing harm to themselves. And the place I'd want to start is something that sounds quite simple, but it's really important, which is suicide is a behavior. It's not a mental illness. By behavior, I mean it's like fighting or singing or any other kind of thing. It's something that you do, there's a motivation behind it. But if we come back to my dividing out these groups of chronically ill into three, the big group actually is demoralization. It's three times fold of other kinds of low moods in terms of who may actually hurt themselves. So, how do you detect that risk? How do you respond to it? Um, a good place to start is to think about why would somebody want to end their life? What's the kind of motivations for that? Well, if I go back to the story of my visit to the In Street clinic, and I said, there are folks that say when I walk out the door, I'm not a dialysis patient, I'm a businessman. And there are others that say, I feel like I'm just being punished. What made life worth living for me has been taken away. This is the more demoralized group. So I often will ask somebody if it sounds like they're struggling like that, are there days where it feels like life is not worth living? I don't use the word suicide. I just say, are there days where it feels like life is not worth living? Because I know that half of us, and certainly myself, there's been some morning I would get up and would feel that way. But if the answer is yes, then I can ask, are there times where you would wish not to live? And I'm saying that kind of using a negative of a negative instead of saying want to die, because there's a lot of stigma about suicide. But are there days where you would wish not to live? And then if the answer is yes to that, then the question then becomes, have you actually thought of ways of wanting to end your life? If the answer is yes, the big item is, have you taken any step to put a plan in place? The number I use is around 17% of just a general population have some days where they feel like, I wish I would not wake up. Vague thoughts like that aren't terribly high risk. But if somebody makes a plan, over half people will in some way act on it. Now, for a psychiatric consultant myself in the hospital, I would start running through all the different stories I know. Patients who have hidden away cords to strangle themselves, or scattered out buildings that they could jump from, or hoarding pills so they would always know I have enough, I could do an overdose, researching the internet, looking for ways, what would be the dose of amlodipine or whatever medication they're on that it would take to end my life. And I think through motivation. What would motivate a person to want to die? Well, I've started out these comments talking about, my visit to the In Street clinic, where it some individual that feels like so much has been taken away, there's nothing more to live for. Or else I can't stand the misery, but it's really to escape pain. Now, that's intuitive for most people, that if somebody wants to die, they really just want to escape pain. But that's not the only motivation. That's probably number one, but number two is often shame, the sense that I've failed, I've let people down, I've disappointed my family, I've disappointed my spouse, I don't deserve to live. There was a very well-known story, like all over the Washington Post years ago, about a Navy admiral who committed suicide. What had happened is that he was wearing some military pin, and it turns out that you only wear this pin if you're in active combat. He wasn't. It got treated like an expose. He felt like he brought shame on the Navy and ended his life. Reunion. If you think about suicide, a lot of people, the first story they'll think about is Romeo and Juliet. These were not kids who were depressed. They were teenagers. They were in love, reunion, a wish to join someone else in death. You do see that sometimes with teenagers. You also see it sometimes with elderly couples, where one person, after a long relationship, dies and the other chooses death to be in reunion with them. Occasionally, what we call ecstatic suicide, it's not an intuitive name, but this is someone who believes, you often in a religious or spiritual way, that death is just a portal to a better life and ends their life in, I've had multiple patients. In the Bible, Jesus says, I go to prepare a place for you. In my Father's house, there are many mansions. And I can remember a man who had tried to slash his throat, his arms. And he said, my only hope is Jesus' salvation. I just want to be with Jesus. Now, some of these are uncommon, but for a psychiatrist, all of these run through my head when I'm meeting a particular person. But, our talk today is about kidney disease, end-stage renal disease. So the questions more focused are, what are the ways that this illness can take away from a person's life enough meaning, enough pleasure, enough purpose that life no longer feels worth living? Or, for rare, but sometimes someone feels like, I've just become a burden on other people. I don't want to burden my family. I don't want to burden them with caring for me. I don't want to burden them with financial costs of running up medical bills. If can pick up the person at risk and kind of figure out, what might be the underlying motivation, realizing that in truth, there are states of life that are worse than death, and that has to be respected. For most of us, there would be some state we could be put in where we would feel like death is a better outcome than my continuing to live on this face of the earth. So if I know that somebody's at risk, and especially can get a sense about what's the motivation, then it actually becomes a much more doable task to help this person find sources of meaning, of hope, of gratification. There's a quote from the great Russian writer Dostoevsky. His book, I will misget this at the type, but the quote is, a human being is a creature capable of bearing infinite suffering. And I always add to it, provided the suffering has meaning, provided you don't do it alone. So let me kind of come back and kind of recap, because I'm kind of hitting on different things, but I thought probably the theme of depression would be the most relevant thing to talk about today. And if you're talking about depression, you pretty quickly are also talking about risk for suicide. Some of you may know Dr. Paul Kimmel, one of our big major figures in nephrology at GW Hospital. And Dr. Kimmel did a lot of his research with our psychiatry department, and he studied depression and end-stage renal disease. I can remember him putting a slide up. One side of the slide were symptoms of depression. The other side of the slide were symptoms of uremia. And it's a lot of the same. So identifying that somebody has low mood, and here, this is where you often may need to get a psychiatric consultant to come help out the diagnosis. Identifying that group of people where they cannot feel any pleasure, they only feel pain, they're numb inside, they need psychiatric help. In the middle group, just grieving many losses, most need a community, a relationship of support. And it doesn't have to be a mental health professional. This is where clergy, chaplains, close friends come in. But the other largest group of demoralization are folks where the question is, how does it still matter that I'm on the face of the earth? I've got this disease, it's taken away many things, and the conversations are about purpose, about meaning, about how to feel the communion of trustworthy relationships. And I can just say flatly that if those questions can be answered, people choose to live and find meaning in the living, even if it involves a lot of pain and distress. So it might be good maybe to pause here and just see are there questions, because I'm taking a particular tack, but the question about mental health and kidney disease is a really big one, and that can go in many different directions. We could be here all afternoon. Uh, but are there other questions that we already have? I can pick up and talk about another topic or two, if not.
Well, it's been great thus far, Dr. Griffith. I'll ask you a question because I think you've touched on a couple of things that I think is very germane to our patient population. Um, you know, obviously, I'm a transplant surgeon, and we do a lot of screening of patients that come to us, and kind of like the way you broke it down, we need to determine, is this person just sad, or do they have chronic depression? And the dividing line for us oftentimes is what you said about, is this person suicidal? Do they have a plan? That sort of thing. So I, I would just like to pick your mind, so to speak, as to when should we be concerned? In other words, the number one prescribed medication, or one of the top prescribed medications in the world today, are antidepressants. And a lot of these patients may even be on a antidepressant medication, but have never seen a mental health professional, maybe the social worker in their dialysis unit, but they've never had a psychoanalyst or a
Yeah,
psychiatrist. And I just wonder, if the patient is already on antidepressant medication and tells you that they've been depressed and it's beyond situational depression,
yeah,
how do you ferret that out as to who we should be sending to someone like you versus who we should not be so concerned about?
yeah. Well, you're asking a great question, and this would be sort of a Nobel Prize level answer, which is that, and it's something that I'm often speaking strongly about. In psychiatry, we have a diagnostic system that's very inclusive. It catches a lot of people in distress. It is not a very effective system for answering the question you just asked, which is, uh, having a chronic illness like end-stage renal disease can be a hard burden. So, who is just kind of having a natural response to a hard situation, and who has what should be treated as a mental illness? What I can say is, and it's basically giving you what I teach my residents, which is uh, we don't have a foolproof system for making that distinction. At bedside or in your office, I can give you three criteria that tend to pick out people that are depressed. It's not just a natural response to circumstances. Uh, the big item is the term anhedonia, the inability to feel pleasure. The question at bedside I often ask is, can you still enjoy things? Somebody you'd like to see comes to visit. You get your lab results turn out well. Can you feel it? And when the answer to that is no, that is the first big red flag that this may be somebody who actually has depression that goes beyond just kind of a normal response to situation. The second and is I'd say guilty ruminations. Just turning over and over thoughts like I've let people down, I should be punished, I've failed, I'm just a burden. When these thoughts go over and over and over and over, uh, that's what you often see with depression as a mental illness, not just demoralization. And then the other is suicide. The and this is not a clean distinction. Certainly, as I said, Romeo and Juliet, neither one of those were depressed. They still committed suicide. But suicidal ideation is common with a psychiatric depression. It's uncommon with demoralization, although it can. I mean, this is a hard distinction. I mentioned the Sloan Kettering research with cancer patients, and there they actually found that demoralization had threefold more suicidal ideation than the clearly depressed group. But those are the three criteria I'd start with: suicidal ideation, guilty ruminations, particularly anhedonia.
I got you.
And now, the step beyond that is to use, we do have several uh, well validated, standardized methods for quantitating severity of depression. What's often regarded as the gold standard is the Hamilton Depression Scale. I keep it memorized. Every patient I see, if there's a question of depression, I go through it, which doesn't just say yes or no depression, but it gives you a number. And the Hamilton scores best correlate with those who do or don't respond to antidepressants. So I'm always pushing my residents, to use a scale that's been validated. Don't just make a global impression, depression or not. Uh, Now, this can be incorporated into a clinical setting, like in your clinic, because there are some self-report scales. The one most commonly used is the PHQ-9. It has 9 questions. Your patient can score it. And if the score is above 9 or 10, that puts them in a high risk for a depression that needs to be treated as mental illness. It's not foolproof. It's a screening. And that's why I got the question, well, we could just put that on the website and have all our patients in the MFA take it. You're going to get so many false positives. It'd be a useless exercise. It's a screening device. But if you score high on them, then to have a more focused in conversation with a mental health professional. But this is the hard question. I'm working on a book, which is about my work with hope. And hope is a practice, meaning you treat it like it's a spiritual practice. It's something you do. It's not something you feel. And you practice hope by getting clear about an important value, commitment, relationship, and just taking a step towards it. And this goes to the kind of listening I do if somebody has depression. That I'd like to know that what matters most in your life. How does it matter that you survive this disease, that it doesn't overcome? How does it matter that you're still? And we have that conversation, and whatever that is, all I'm interested in is just taking a step towards that direction, not asking anybody what they feel. So this is something that actually you don't need to be a mental health professional to do. It does mean having 2 conversations with your patient. The first one is, what is this disease taken from your life? And then turning that conversation to, how do you respond to adversity? How have you responded in the past? And then we brainstorm, how can we bring that to your situation now? But like I said, the question you're asking is most important. The fact we don't have good ways to discriminate means that millions of people get given antidepressants for whom they probably aren't that indicated, versus alternatives. And what I teach in our program, I give our residency articles. Antidepressants have the smallest effect size of all the medicines we use, meaning that if you get antidepressant or you get sugar pill, how much difference does it make? Our antidepressants have the least of impact.
Wow.
Now, what has a big impact? Try alcohol or methamphetamine. You know that one shot of tequila and any problem in the world is better. The problem is that there are consequences, there's side effects. But I say that because we have a word antidepressant, but the medications, it's more like giving someone steroids or Tylenol or something. They don't have often the needed impact.
Well, I want to jump in and ask you another question, well, two, because you piqued my curiosity. Number one is, we also do liver transplant here, and when we talk about liver disease, we often talk about this huge spike in alcohol abuse that happened as a result of the COVID pandemic. We just saw
Uh-huh.
never in my career have I seen so many more people drink so much alcohol. So I'm wondering if these environmental sort of issues can impact. You mentioned hope and that you're writing a book on hope. And, just a few years ago, we had a president who hope was such a big part of his whole message. Yes, we can, hopeful, hopeful. And, and now, take politics out of it, but now we have an administration that is not so hopeful, in outlook. And I'm just wondering if these big environmental like factors, like stressors like COVID
Yeah.
and the way that the zeitgeist that is in, particularly in this area, in the Washington metropolitan area, do you see that there's a spike in mental disease as a result of what's going on in the environment?
Well, not a spike in terms of the category I'll say is mental disease. This would be schizophrenia, bipolar disorder, panic disorder. We COVID did not produce big jumps in those. What they did big jumps in is like demoralization, other kind of stress related symptoms, and there is a big problem with hope, which is that if you encourage someone to feel hopeful and you can't change anything about their circumstances, that frequently boomerangs.
Mm.
People feel worse. That's why the philosopher Friedrich Nietzsche said hope is the greatest of all evils.
Mm.
It only prolongs torment. Now, what I do is back that up to what I talked about earlier, that what I'm work with, write about hope as a practice. And this is not about trying to feel hopeful. It's about getting clear about an important value commitment, including commitment to staying alive and just taking a step towards it. Not It's a little bit like in 12 steps, Alcoholic Anonymous, they say fake it until you make it. They don't get preoccupied with you keep doing the program. And that's the way I work with. Yeah, I mean, our consult service sees numbers of transplant patients who had alcoholic cirrhosis, got a transplant, still struggle with drinking. And to win that contest, you need clarity about what really makes life worth living and a commitment to keep stepping in that direction. So that's, um, but back to your original question, we actually, people did not pay enough attention at the time we said this to the Toronto and Hong Kong experience with SARS virus. That virus was not community spread. If it had been, it might have wiped out a fourth of the world's population because it's a much more vicious disease than COVID. But what we learned from the Toronto hospitals where they had a lot of SARS patients was not big jumps in the serious mental illnesses, but like I said, relationship problems, despair, um, struggles coping, what you would say are more stress related effects, not your big psychiatric illnesses.
Yeah, I get it, and that's a great point. Another thing that's been kind of in the news lately, and we've seen it in our practice as well, is that we have more actual psychiatric illnesses, and where and it tends to track along with poverty, particularly being unsheltered or
Yeah, sure.
without a home. And of course, in the Washington D.C. area, we've had a lot of trying to move these homeless people. But like I said, even we've had transplant patients, even though they go through this social
Yeah,
clearance by our social workers. Sometimes these people are kind of on the edge. They're housed, and then by the time, because sometimes they're on the list for a while before we transplant them, and then something would have happened in their precarious housing situation,
yeah,
and they become unhoused. Um, I take it that you are quite familiar with the fact that so many of these people that are in this categorization have major psychiatric
yes.
problems. How do you deal with that? Because you know um, people always ask, well, why don't these people that are on the street simply take their medicines and then get their lives back together? But I take it it's a vicious cycle, right?
Yeah, no, that's a great point, and it was shift away from demoralization to what it's like to have chronic schizophrenia or chronic bipolar disorder. The life expectancy of somebody with chronic schizophrenia on average is 15 years less than the rest of the population. And that's all about most of that is not suicide, it's medical illness. Poverty is the biggest adverse mental health factor, particularly for our children. And and we see this constantly. Through the winters, we will have patients with living in a tent who come in with gangrenous toes. Uh, we have someone to discharge after a lot of intensive medical care and IV antibiotics for chronic soft tissue infections and so forth. Finally, to discharge and are discharged to the street. Where uh, for physical health reasons, they fall prey. Uh, this is I'm a big believer in housing first, community over on New York Avenue. This is where you work to get somebody into a place to live first, and then you focus on treating their substance abuse and mental illness. Housing first models are under attack right now in the current administration in terms of defunding. Um, but it's I agree completely. I think with your question. That I'm assuming transplant is well. I don't know. Maybe I'll include bone marrow transplant with it. This must be one of the most expensive endeavors in our healthcare system.
Absolutely.
But after that huge investment, we too often discharge people to a street corner in a tent,
True.
and it's just one of our great moral questions.
Yeah. No, I agree, and it's economically stupid as well. If we did a better job with these chronic diseases, we wouldn't have so many uh, people even needing transplant. And then you're right. I mean, we spend all this money. I mean, it costs the insurance provider well over $150,000, if not more, to get at least a kidney transplant and much more for a liver transplant. And yet, the support that's offered after these expensive ventures are oftentimes not existent. And our argument is always like, wait a minute, we've made this huge investment. Let's at least protect our investment by making sure these patients have treatment for their chronic problems. Because, like you said about people that die unhoused with schizophrenia or whatever, they're dying of chronic medical issues. Well, the same thing happens in our patient population. It's their chronic medical problems that often lead to problems after transplant. Um, my next question for you was going to be anxiety,
Hmm.
because there also seems to be a connection
Yeah.
of people that have anxiety then leading to depression, or do they feed off of one another?
Yeah, no, it's a great question, and one that does not have a firmly settled answer. I discovered it myself when I finished residency. I was interested in the rating scales we had for anxiety, for depression. So you had patients, I would give them both scales, and I was baffled because I would have somebody coming in with panic disorder, but their depression score was as high as the anxiety one, or the other way around. That somebody would come in only talking about depression, but when actually given a scale to be asking specific questions, they were having a high anxiety.
Right.
There is an argument that with generalized anxiety disorder, this is just feeling edgy, keyed up, crawling out of my skin, chronic, that we may just be looking at two phases of one disorder. That anxiety involving more your fear circuitry of your brain, and depression involving more, the reward center brain. Uh, but if there's good news to it, it's that they both respond to sort of the same treatments. Every anxiety disorder responds basically to every SSRI.
uh,
And although we say antidepressants, I've argued it for years that the data is they actually are better for anxiety than depression. And then 2 years ago, we had a study, the PANDA study, come out of the UK. Big study. They got like 175 primary care practices, randomly gave everybody either 150 milligrams of Zoloft or else placebo. And the average scores showed no effect, no separation uh, on the depression items, but some of the anxiety scores got better. So the study did two things. One was, again, bringing home the message that these are not terribly potent drugs we have. They probably work a little better for anxiety than they do for depression. And the error in it, because it's really not that they don't have any effect, it has to do with the diagnostic side. We're not discriminating people that have a normal response to adversity from people that have kind of an autonomous mood disorder. Our diagnostic methods aren't making that distinction clean. So we wind up treating a lot of people who, what I say to at bedside is, what you're going through is what most anybody would, given your situation. That doesn't respond to antidepressants. But if they often are going to be given antidepressants. But, if you have generalized anxiety, panic disorder, uh, responses to serotonin reuptake inhibitors and SNRIs they're drugs of choice.
well, let me ask you this. There's so much in the lay media about mood elevators, like I don't know, dark chocolate or uh,
Oh, yeah,
caffeine. Are there things like more, I guess, homeopathic
yeah.
sort of things? Are there things that you tell your patients? Oh, you know what a good mood elevator is? Dot dot dot. This thing or this activity that naturally will elevate your mood.
Well,
I know one of the answers. One of the answers is golf. I know that because I play golf. So,
okay.
yeah.
What it is maybe is is a point I should have made earlier, which is that the effect size of psychiatric treatment is among the highest in medicine. It's often put more like 0.7, 0.8. Most of internal medicine is going to be more around 0.45, something like that.
Mm-hmm.
We don't have clarity about our diagnostic system, but for selected patients that are appropriate for the treatments can be effective, provided, and this is my big statement, this is my soapbox, you need a program, not just a treatment. You need a program, and in that program should be getting relationships into a good state of well-being, finding a good balance on stress and rest and enjoyable activities, uh, preferably aerobic exercise, but some kind of exercise. In addition to that, if you take an antidepressant medication, if you may also be in psychotherapy, that works remarkably well. But it's in our culture, we've been forever too wedded to the active ingredient philosophy,
Right.
where you find the one active ingredient, do that, everything is better. You need a program that really includes your relationships, includes the internal conversations with you have with yourself about what life makes is worth meeting. So having said all that, um, I don't know if you know Misha Kogan with our complementary medicine program.
Mm-hmm.
He always says, if people have been doing it for 2,000 years, it's done no harm. There's no reason not to do it. So,
Right.
some people will take various herbs and certainly there's population data about 3 omega fatty acids. Um, and dark chocolate has a lot of, I forget my amines. So to put together a program that would include all these things is great. I think if you only eat dark chocolate, it's going to be a problem in multiple ways.
Yeah. Well, here's one of my questions, because this is something that seemed to have made full circle. I remember, the horror movies of the guy getting, electric convulsive therapy.
ECT, okay.
Yeah, and back in the 70s and stuff. And now it seems that it's come back around. I mean, what changed?
Yeah, no, nothing really changed. It's just that movie with Jack Nicholson,
Right.
for a generation, gave such stigma to ECT that everybody avoided it. And we're still kind of at the competing theories level as to why, but it is flatly the most effective treatment for depression that we have. And for mania, bipolar disorder, um, I give all these articles out to my residents, that when they optimize the very best regimen of medicine, match that up against ECT, ECT is like 70% effective versus 40.
Wow.
It's a big effect size. And due to research and methods, we're much better able now to deliver an electric shock that does not affect language areas, so you don't get aphasia afterwards. Doesn't affect memory so much. Just do it to one hemisphere, not to both. So there's been a lot now to minimize side effects, so that what you see in a movie like that has no resemblance. But for geriatric depression, in my age group, people that get bad depressions, response to medications is like 60%. It's a very weak, but the response to ECT is robust.
Wow.
So for geriatric depression in particular, for patients with catatonia, where they kind of go into a freeze state, it's often the only thing that's going to work. Pregnancy, it's safe in pregnancy and can be safer than given the medicines. So it will be reserved for people that have, I started out this beginning about separating out between, grief and
Sure,
demoralization.
right. Yeah.
This is going to be people that have refractory depression, but it's remarkably effective, very few side effects, and it's very much on the ascendancy. And there are newer neuromodulation methods about using, say, an MRI scan to kind of target magnetic pulses to certain areas of the brain. There's a
Yeah.
lot that's being researched now, and then the psychedelics. I had enough friends when I was in college on psychedelics that I never saw an improvement in their mental health. That I have a certain amount of skepticism. But
Yeah, unfortunately, those have made a comeback as well. More
yeah,
people are taking psychedelics for pleasure, and
yeah,
it's a problem.
yeah.
All right, let me ask you about the magic medicine that people are taking for a whole host of reasons. GLP-1s, they seem to have some psychotropic effects as well, right?
Yeah, Ben, it seems to me like I don't know the literature intensively well, but wherever I pay attention, it seems like it's all good. That protects against diabetes, weight, and it may be the anti-inflammatory aspects, but seems to be improvements in mental health.
Yeah.
Uh, what's coming out so far that I've seen is very promising. Um,
Yeah, like I said, they're magic medicines because, as you said, they seem to do. They definitely do better with obesity and diabetes, but also, you know, we're seeing it give better cardiac health, better kidney health, and so with us, so many of our patients coming into transplant or have
yeah,
obesity as a problem, so they'll be placed on the GLP-1s, and the ones that tolerate it, there are side effects, including nausea,
yeah,
vomiting, that kind of stuff. But if they can get through that period and tolerate the medicines, it tends to make them feel better, and not just because they're losing weight. So yeah, they are magic pills or magic injections because they're mostly injections.
yeah, and we have a lot of use, with our psychiatric populations. Uh, a lot of our, not the drugs, we've been talking about antidepressants today, but if you cross over into the atypical antipsychotics, uh, they often can produce metabolic syndrome,
Yeah,
particularly, and it's higher for some genetic groups than others. Central Americans, it's like 30%. African Americans is very high. Uh, Patients who have died from acute ketoacidosis with taking olanzapine, which we use all the time in the hospital.
hmm
A different conversation, but it'd be great if there were a future with these drugs as countering. Usually, you don't want in medicine to give a drug to counteract the side effects of another drug, but we need something for the amount of uh, high lipids, weight gain,
yeah,
cardiac risk that are side effects of drugs that we do use.
yeah. Well, and that segues right into the next question I wanted to ask you. Talking about side effects in our field, when these patients come in for transplant, we're giving them very large doses of steroids, and just the steroids can push them into a delirium.
Yes.
And I'm wondering on both sides, like, are there patients that we should be more clued in that they could be at risk for
Sure.
delirium? And then is there something that we could do prophylactically to prevent the delirium in those patients that are at high
Yeah.
risk? I was wondering.
Yeah, delirium as well as a large group of developing some severe depressions and a smaller group, sometimes mania.
Right.
And interestingly, there actually are studies suggesting that lithium, pre-treat with lithium before giving the steroids, may have the value you're looking for. When I was at Massachusetts General in residency, a guy a couple of years ahead of me, Bill Falk, at that time, they're in the northern latitudes, high rates of multiple sclerosis. Patients would get an exacerbation, come in and be given big doses of dexamethasone. A lot of them would become manic. So Bill just got the idea, well, let's just randomly treat every other patient with lithium. And he demonstrated, he got this published in JAMA, controlled study. Yeah, that pre-treating with lithium would block the mood dysregulating effects of well, I guess that was dexamethasone,
Yeah.
steroids. And if you look at the basic science, and I've asked this question to some of our NIMH researchers, that lithium does several neuroprotective effects within the brain. That I asked when Hussein Imanji was there, he headed up the anxiety program, and said, it sounds to me like that if you're going to get a big dose of steroids in the hospital, you should pre-treat everybody with lithium.
Yeah.
He said, well, the basic science would look that way. So actually, I have not kept up to where the status of that is now, but there's multiple pathways through which steroids can do destabilizing things to mental health.
Oh yeah, we've seen it numerous times, and that's interesting because as you know, lithium is one of the causes of kidney disease long term. But I would guess in a short period of time, being on lithium,
oh yeah,
is fine.
Yeah,
funny because I've had some patients that are bad on bipolar, and sometimes even because I know now you guys have a much larger armamentarium to treat these bipolar patients, but some of these patients, even after transplant, the only thing that works is lithium.
Yeah. No, I'm a big fan of it. The problem has been there's no pharmaceutical company that has an investment in lithium.
Right.
Now, there's big advertising around whatever the latest atypical is.
Yeah.
But
yeah, it's cheap.
lithium,
It's a relatively cheap drug now, right?
yeah, it's like salt, and but it's the only bipolar drug we have that reduces suicide rate sixfold. So that everything is so good about lithium. In fact, even recently in the papers, there's questions about it may be prophylaxis with Alzheimer's.
Oh wow.
So I think if you look at all the data, everybody would want to take a little bit of lithium.
Huh. Yeah. Well, like I said, I've seen patients just swear by it.
Yeah. Yeah. It started out as a salt substitute, and then some people died at the dinner table. So it got banished for a long time.
Yeah.
But properly dosed, this is active in current, that it may turn out to be have some prophylaxis with neurodegenerative disorder.
When you prescribe it these days, do you check levels? You check serum?
Yeah. That's the thing.
Yeah.
It's got a 24-hour half-life. You need to get the range where you keep your serum level. Prophylaxis 0.7, sometimes higher for acute treatment.
Mm-hmm.
But that is one, and that is the reason I guess that we often aren't using it as much, is because you need to check thyroid, you need to check your electrolyte, renal function.
Okay. Well, this has been great, Dr. Griffith. Let me. I don't know if Dr. Callender is still available. I'll ask if he has any other questions because I don't see him, but I don't. Yeah, I don't see him popping up. But I think this has been phenomenal because, like I said earlier, anxiety, depression, and of course, suicidal ideation. These are big problems in our patient population. This is true pre-transplant as well as post-transplant. But this was an encyclopedic sort of review, and we really appreciate it. I don't see any questions coming from the audience currently, but what happens is, this will continue to run. They will, people will go online and they will get questions afterwards. So I would like to try to have a reservation for you to come back.
Okay.
And maybe, whatever questions come back to us, we can utilize in our next program. But we really, really appreciate this. This has been a great review of psychoanalysis, or more to the point of depression and suicidal ideation in transplant. Um, we've been here with Kidney Talks, and we will be back in 2 weeks from the from George Washington Transplant Institute and the Ron and Joy Paul Kidney Center, the Pennsylvania Avenue Baptist Church, and MOTEP. And this has been another episode of Kidney Talks, and can't wait to talk to you guys soon.
Okay.
Bye bye, and thank you.
Thank you.